Welcome back to the Higher Form Podcast. We're here every week having real conversations with leaders, coaches, and everyday people about what it takes to become your best. We know life will test you, and we're here to share practical tips, tools, and relatable stories to help you build the highest form of your life. This week, we have Dr. Kyle Gillett on the show with us to talk about the science of obesity. If you are not familiar with Dr. Kyle Gillett, he is a dual board certified family medicine and obesity medicine doc. He is the founder of Gillett Health and Gillett Aesthetics. Kyle is known for his pillars of health and specifically integrating in exercise, nutrition, hormones, peptides, and medical science collectively. The thing I respect most about Kyle is that he is one of the rare forms of a doctor that looks and practices what he preaches. So welcome to the show, man. I'm really excited to get a chance to chat with you.
Thank you. My pleasure.
Yeah. Well, cool. I think we'll just jump right in. The question that I think will really steer us down the right path is just really learning like what made obesity and metabolic health the main focus for you.
Yeah, supply and demand, actually. So I'm from the Kansas City area. I was homeschooled. My father is a family physician. He was one of the first people that started College Park. I think he was a CMO there for many years.
Okay.
I actually hired him a year ago, Dr. Mark.
That's awesome.
But, I saw how he really cared for his patients. He prayed for them. He cared for them holistically. But it was the conventional medical system, really good at fixing broken bones, and even some things like rare cancers are now being cured, et cetera. Mm-hmm. But not good at preventing prediabetes, diabetes, and metabolic syndrome. Extremely common. In fact, most people had that. So I knew as I went through my training, I wanted to provide, full scope holistic medicine, but be really good at what the system misses. Mm-hmm. And I noticed that is things like the lifestyle pillars and metabolic health.
Yeah, let's talk about that. I know you're really well known for your pillars of health. Can you just break that down for people so they can understand that perspective that you bring to the table?
Yeah, so it sounds cliche because I say it so many times, but the lifestyle pillars are going to make you healthier than any pill, whether it's a medication, supplement, peptide. They are more powerful than any of those. Mm-hmm. And their diet, exercise, sleep, stress, social health, spiritual health, actually, and then sunlight, which just means being outdoors. It includes heat and cold exposure, et cetera. And I used alliteration for the last 5 of them, but all of those should be prescribed in medicine.
Yeah. And I think that's what's interesting is you don't find a lot of those methods being used as prescriptions to help, like you said, proactively and preventatively. When did you think you really recognized that there was an opportunity for you to create something that was very different, but also a big opportunity for you to kind of like open up this practice and this approach you take?
Yeah. Well, I knew even when I was in high school and probably even middle school that I wanted to be a doctor, mm-hmm. and that I specifically wanted to do family medicine because most people, they call them gunners in med school. They basically want to do the highest status, highest income specialty. Shocker, it's not family medicine.
Yeah.
In fact, hundreds of spots in family medicine residencies go unfilled every year, but there's, so many applicants to all these subspecialties. Mm-hmm. So unfortunately, a lot of the students that are not as good academically do not go into family medicine, which is the most difficult specialty. It's everything. It's a very wide scope. Yeah. So what ends up happening is we just follow algorithms and let insurance companies dictate care. So by the time, even before medical school, even in college, I could see that there was an extremely unhealthy population. I liked playing sports, and mm-hmm. Because of that, actually very late in college, I got into lifting weights, and I also ran track.
Okay.
But I knew that there was more to what people needed to do other than just taking pills.
Yeah, for sure. I think that's a very interesting way to look at it because, to your point, as someone going through medical school, looking at, like you said, the what'd you call it, the different specialties?
Yeah, there's the high status, high pay specialties.
High pay specialties, yeah.
And then there's primary care, psychiatry, pediatrics, family medicine. Generally, there's literally 100 people that told me I'm wasting my career by going into family medicine.
Yeah.
And I tried to keep an open mind, but I always knew in the back of my mind that I liked it. And I was involved in exercise as medicine interest groups and food as medicine interest groups. So mm-hmm. a lot of people are in med school, and then they go into a residency that works them really hard, doing nights, et cetera. I did the same thing.
Yep.
And they get burned out, and then they just forget. It's kind of sad.
Yeah. Mm-hmm. Let's reframe obesity, because I think it's one of those things where people don't ever understand, like, is this something that's more of a complex disease? Is it more of like a simple mismatch in calories? You hear the calories in, calories out thing. Can you paint your perspective on obesity and whether that's more of like a nature nurture type thing?
Yeah. So two things can be true. Obesity can be an extremely complex disease of many different root causes, not just one root cause.
Yeah.
And the laws of thermodynamics can be true in
Yeah.
physics. So the calories in obviously do eat calories out, equal calories out. But there is a lot of nuance within that. And one thing that many people don't realize is, they're trying to track every single calorie in and every single calorie out, and non-exercise calorie burning, which we call like non-exercise or non-activity thermogenesis.
Neat.
You're basically, yeah, neat.
Yep.
You're basically fidgeting more like this or moving your arms more, etc. It's just everything that's not your basal metabolic rate. And then it's also not exercise. That is very difficult to account for.
Yeah.
And that's why a lot of the old school obesity medicines are basically just stimulants, repurposed ADHD meds.
Yeah, it's
really.
like phentermine and type drugs.
Yeah, or diethopropion is a
Yep.
monoamine like bupropion, which is Wellbutrin.
Yep.
Contrave has Wellbutrin in it, although supposedly it's, anyways, not to rabbit trail too much, but because it is a complex disease, then yes, you address all the different potential causes. Insulin resistance is just one of them. Sleep apnea is actually a big one. If people are sleeping more, then that actually has a great impact on body composition, both fat loss and muscle gain. But you also have to address the elephant that's in the room of caloric intake.
Yeah.
So it's still important to talk about foods of high caloric density and how, eating 2 handfuls of nuts every day, while it might have a lot of micronutrients, is not a great thing for fat loss. What I see happen a lot is there's this dichotomy where you try to separate things, and then you have what I call the CICO bros, calories in, calories out bros.
Yeah.
And they are dismissive, and they try to invalidate the opinion of everyone else that points out other things. I talk about a hormone called leptin because I love talking about hormones.
Yeah, I literally
And then I have
had
people,
that on here.
Yeah, like I know like Lane Norton and the other kind of like he's cool, he's good. But there's other CICO bros, and I won't name them, but people are commenting, tagging them in the comments.
Of course.
I mean, am I not allowed to talk about some nuance, or do I have every post I make, I feel like I don't have to say calories in, calories out is the most important thing.
Yeah, of course. Well, I mean, I think that being able to understand that this is so much more complex than that, it's easy to have an opinion and write that off. And I think it's like sexy for social media for people to have that really hard opinion that leans towards the lifestyle side of it or just the nutrition side of it. But recognizing that there is a deeper like physiological thing that's happening here, I think is something that maybe gets overlooked sometimes.
Yeah, and I always try to give actionable tools as well. I don't want to become one of the doctor influencers that says everything's just too complex. You have to ask a doctor a question before you do anything.
Yeah.
Before you go to the bathroom, ask the doctor to make sure you're not going too often. So there's a lot of takeaways, but one of them is people should track their protein. And then the second one, which most people don't do, is they should track their fiber. And it doesn't have to be every single day. It can be as simple as 3 days a month or 5 days a month. Take your normal days, average them, and then see what your average is.
Yeah, that makes a ton of sense because obviously not every day is going to be exactly the same. It's going to be hard to make it perfectly like I get exactly this many grams today and tomorrow and over time.
What I used to do is every month I would track for 3 days. And let's say I had averaged 200 grams of protein, but I only averaged 22 grams of fiber. I would up the fiber. I wouldn't go to 40 right away because that's, you're asking for some bacterial overgrowth.
Yeah.
Especially depending on the type of fiber. But without getting into too much nuance, I slowly increased to about 35 grams. And I think everyone should be getting 30 grams of fiber per day.
Yep.
And if it's hard to tolerate, maybe they're on a GLP-1 and maybe they're on too high of a dose. Maybe they need to decrease a little bit. So yeah, track your fiber and your protein. Depending on the person, some people will track for a week, some people will track for 3 days. And there is a small portion of people that use apps like the Carbon app, and there's other good ones too. And they can track everything for a period of time, but most people can't do it indefinitely.
That's what we've found as well. Yeah, it's just not a very sustainable habit. Used great, like you said, when it's done intermittently, like as a tool. Hey, I'm going to look at this window of time and see what makes the most sense. But I love it because a lot of what you're talking about are things that we talk about more on like the lifestyle things as well. And I just think it's uncommon to hear doctors talk about it from the same perspective because of what you mentioned about the lack of opportunity or the lack of focus on taking those lifestyle pillars and applying them to medicine.
Everyone should have a rubric, and I share this with patients too, but it's different for everyone. One of the things that I look for subjectively, if I'm trying to be in a fat loss phase, most of the time, if I eat an apple or relatively plain chicken breast with some spices,
Yeah.
it should taste amazing. Or like a tin of tuna with a little Tabasco sauce. If that does not taste amazing, I know that my diet is, regardless if I've tracked anything else, I know it's not where it needs to be to achieve fat loss.
Interesting. Can you elaborate on a little bit more about like if I'm someone that hears you say like tuna and Tabasco and I'm just like, completely averse to the idea of that? Like,
Yeah, it's the same thing. So like I actually learned this one from my older brother.
yeah.
When he used to go into a fat loss phase, if he was not hungry enough to have a can of green beans, he was like, well, I'm not
Okay, I get
hungry
what you're
enough.
saying now.
I have never eaten a can of green beans. I don't
Yeah.
think I could eat a full can. I just don't like them.
Yeah.
So same thing for tuna. Yeah, it's going to repulse someone, but finding that rubric for yourself of pick a food that is hopefully either high protein or high fiber
Yep.
and that is of low caloric density. Even better if it's high nutrient density, right?
Yep.
And then if you're not hungry enough to eat that, then that's how you intuitively eat. Intuitive eating has a terrible reputation because it's associated with the health at any body composition movement.
Yes, thank you. I appreciate you calling that out because I think it's one of those things where there's a fine line between being accepting and being real with yourself. I think there's a good opportunity to dive into the hormones that influence obesity and don't. And you said you love to talk about it, so let's dive into that.
The one I love to talk about most, the group is steroid hormones or steroid hormones. So there's a lot of steroid hormones, but people know about testosterone and androgens. Estrogen is a sterol-based hormone, and estrogen is actually also helpful for fat loss. I think I don't know if it was More Plates, More Dates. He's who got me into podcasting, by the way.
Yeah.
He convinced me to do Mark Bell's podcast.
Yeah.
But there's a picture of somebody with a really bad aromatase deficiency, a male, and is obese. And that actually increases your testosterone, but crushes your estrogen to nothing if it's like a complete aromatase deficiency. But estrogen can be helpful for fat loss purposes as well. And then vitamin D can actually be helpful too. And vitamin D
is where it comes in. Yeah.
It's actually a hormone. Yeah, it's a steroid hormone based off of the cholesterol backbone.
Okay.
Then you have other ones like progesterone and yes, cortisol is one too. Cortisol is usually overblown. So most people don't have to worry about their cortisol or their glucocorticoids preventing fat loss. But especially as age progresses, it becomes more and more important to check your hormones. The phrase I use is every male and female in andropause and menopause or perimenopause at least deserves having their levels checked and a conversation with somebody about if they're decreasing and if they do decrease, what they should do.
Well, it makes perfect sense. You talked about cortisol. I hear this one a lot. You know, what we do here is fitness-based. And I can't tell you how many times people come in and they're like, yeah, you know, I'm not losing weight and I think it's my cortisol. Like, how would you respond to that if you had someone come in and give you that explanation for maybe why they aren't seeing the progress they want around managing their obesity?
Yeah, I would not send them a meme that is making fun of them, which is what most influencers do. That people are concerned about cortisol.
It's just calories in, calories out.
Let's check it. Why guess? Because it could be, right?
Yeah.
It's possible. Maybe they have Cushing's syndrome or Addison's disease. They're very rare. That's high and then low cortisol. But I would start by checking it along with other things and having a conversation about why do they think it's cortisol? And then they start telling you about your sleep and maybe they wake up super early, so they think their cortisol spiking early. So there is merit to just testing it because then you can see.
Yeah. You talk about like andropause. I don't know that a lot of people talk about that side of it as much. At least in our line of work, we see more women come in conscious around like pre, peri, postmenopausal and effects. Can you talk more about andropause for the men and how that shifts and what that process looks like and kind of how to navigate it?
Yeah. So andropause is not something, at some point, every female, if they live long enough, will go through menopause. That's where the ovaries stop making hormones. The adrenals actually still do. That's where postmenopausal females get some estrogen. But andropause is a term, and there's actually another one called adrenopause, where the adrenals slow down. But it's just where Hormones tend to decrease as time progresses. On average, the average American loses about 5 to 10 points of total testosterone per year. If the average American was very healthy, they would lose less than that. But there's a lot of variables. For example, one reason for low testosterone is iron overload. If someone has hemochromatosis, which is just iron buildup, men don't have menses, so we're losing less iron. And that's why, it's the female athlete triad, for example, not the male athlete triad. But it can actually build up, just like if you leave a shovel outside, it will rust and oxidize. So you can have excess oxidative stress in things like the testes and the thyroid, and decreased hormone production secondary to that.
That makes sense.
So, other things like metabolic syndrome, insulin resistance, sleep apnea, different stressors become more common with age as well. Heat damage is another one that can occur. But yeah, on average, it does decrease. So I think even if someone's not in the andropausal age of, I'd say 45 plus, you should still get a baseline, because most people I speak with wish they got a baseline when they were 20.
Yep. Yeah, because you don't have anything to measure it against if you aren't looking back over the course of time and consistently checking it out. And what kind of timeline do you recommend in regards to how often to assess these things? Is there a certain age where that should increase in frequency?
Yeah, if it's just a baseline, then every year or two, I think is reasonable. If you're trying to optimize something, then you can check things quite frequently. And when most people get their first lab panel, they usually find something.
Yeah.
So it's not necessarily to be concerned about. A lot of people find that maybe they're low on vitamin D, maybe they're low or high on iron, which is called ferritin. And shameless shout out to my company, SageBio.
I was literally just getting ready to think about that. Yeah, go ahead. Talk more about it, man. Because I actually did labs with you guys through SageBio and went through the whole experience before we got a chance to come on. And thought it was really cool how you guys use technology. I uploaded my old labs directly into it, and it gave me a pretty comprehensive report without ever even talking to you.
Yep.
And then getting a chance to go through and do labs through you guys at Gillett Health, then being able to upload that and look at the comparisons. Because it was almost, it would have been May of 2025 when I did my last ones, and then it would have been January or February of this year in 2026 looking at the second one. But yeah, talk more about SageBio and how that whole process works, because I thought that was really cool.
Yeah, so one of my frustrations, even before I was heavily into the health and fitness community, this is 7, 8, 10 years ago, if you wanted a lab checked and you asked your doctor, they would usually say, no, you don't need that. So what happened is these other companies came up, like Private MD Labs was one of the first ones. And they basically offered what's called self-service labs. So you have to choose which lab is good. And then people started having lab panels. In fact, when I helped Derek start his clinic, I was a medical director there. I designed his lab panels and helped design them. He did too. He's a very smart guy and a good person too. But one of my frustrations is a lot of these companies offer markers that you should really talk to a doctor about before ordering, like mercury and Lyme disease testing, because there's a lot of false positives, frankly. Not to rabbit hole too much, but
please do. That's what we're here for.
The other thing is a lot of these companies are just ordering the cheapest marker. So most testosterones that you would order on, think of whatever functional medicine lab company it is going to be a very inaccurate estrogen or testosterone level. And that hurts people like postmenopausal females the most, because their estrogen's very low and their testosterone's also often very low. And it can be falsely high or falsely low. So it's extremely important that they would have an accurate marker. And those markers aren't even recommended to be ordered in those patients. So basically, I thought, well, I can design a product that lets people order the right labs, the most accurate labs for their situation, and at very reasonable margins.
Yeah.
Now, my margins are nowhere near most lab companies because the accurate assays, which is just basically a lab test, are 5, if not 10 times as expensive as far as wholesale cost.
Get what you pay for. Yeah.
The other frustrating thing is a lot of these at-home testing companies say it's 99% as accurate as, a phlebotomy lab, but they compare it against the inaccurate phlebotomy lab.
Yeah.
So I won't talk about it anymore because it's boring, honestly. But long story short, it is a good product. So people can go use it if they like.
I just thought it was really cool getting a chance to see the comprehensiveness without a whole lot of extra effort in there, but then also, like you said, being able to compare and start to stack and have a place where I can keep it all in one place regardless of where it necessarily came from even. But I don't think a lot of people recognize the value of really getting an assessment on things and looking at establishing a baseline and how those lifestyle pillars actually affect that. And then being more science and data based and making adjustments instead of saying like, well, I heard that I was supposed to cut my calories and get on TRT to get in better shape and lose weight and look good. It's like, well, do you have data to do that? Or was that just something that your buddy did? Or did you do it at work? Or like, how do you validate the need to do that? And then also source it appropriately and dose it appropriately and actually have the right interventions and protocols in place.
Yeah, for sure. It does help to have at least someone to advise how helpful is this that doesn't have a vested interest in what they do. For example, my clinic is designed like Costco. It's a wholesale club.
Yep.
You pay a membership fee and then everything else is at cost.
Yep.
Because what happens often is once you're signed up for a clinic, they get you in because it's a free consult with
or like a super
whatever.
cheap lab panel or something like that. That's like, hey, come in, get at this test for $100, and then their margins are on everything they serve you after that.
Yeah, exactly.
Yeah.
So I feel like I try to be unbiased, but 100% of people are biased, right?
Yeah.
So a lot of times they have that unconscious bias if they know that there is profit if I sell this product or medication or peptide to this person.
Yeah. Yeah. So you're going to naturally steer them there, whether it's conscious or subconscious. That makes sense. Let's talk a little bit more about the biology, because I really like how you talked about the hormone side of it. But what about like this whole idea and process behind insulin resistance and the metabolic side, and maybe other factors that aren't directly hormone related around obesity and fat loss?
Yeah, insulin resistance and high body fat percentage body composition is chicken or the egg. So insulin resistance can actually change pretty quickly. If you look at studies on, say, like 3 or 4 days of time restricted feeding or just low calorie days, then insulin resistance can improve quickly. But there is epigenetic switches. Some of it's genetic, but most of it's not. But there is switches that make it more likely that some people are more insulin resistant. And it's a bit of a self-fulfilling prophecy once you start that process.
Yeah.
In general, my rule of thumb is once you're at a body composition, in order to redo your set point.
That's literally something I was going to ask you about here too. Yeah.
Yeah, at least 6 months around that body composition.
Okay. Yeah, I've heard everything from 6 months to 2 years to everything in between. Can you explain a little bit more about set point, just in case people don't understand maybe what that is?
Yeah, your body is accustomed to be a certain weight.
Interesting.
So if you're a very high weight for 20 years, then it could be 2 years at that same set point.
Yeah.
One thing that GLP-1s are great at is helping you get to that set point and helping you stay there. You just have to be careful not to come off too fast.
Yeah, let's talk a little bit more about GLP-1 medications and like when maybe they make more sense for someone or when maybe they don't.
The way you think of this is it is a tool. If you break your ankle, then you'll use a crutch for a little bit, be in a boot. You don't want to go in a wheelchair and stop moving altogether. The problem is when you dose GLP-1 so high, there's no hunger drive. When you remove that, you rebound. And some people take them just to decrease the food noise.
Yep.
If you don't keep increasing the dose, yes, the food noise goes away, but only for about 2 to 3 months. So if you're taking, say, 2 milligrams of semaglutide or 5 milligrams of tirzepatide or 1 milligram of retatrutide, then 2 or 3 months later, it will start coming back. And then people are tempted to keep escalating the dose. If you de-escalate slowly, then it can work. But what I see is people do just a GLP-1. They don't use their other tools. They don't use their fiber. They're not supplementing with sun fiber. They don't get their protein in the diet. And they're not fueling enough for their workouts as well. So instead of like, if people ask, should I make myself eat on a GLP-1? Probably not. You should probably just decrease the GLP-1 and you'll naturally fuel a bit better.
Yeah. It seems so logical, but I think it's one of those things where it's hard for people to understand whether or not it's solving the problem or if it's managing the problem. You know what I mean?
Yeah. A lot of my patients are on twice weekly GLP-1s because a lot of them only have, their half-life is 5 days. So it's actually peaking and troughing quite a bit. And the other things I'd watch out for is gallbladder and the kind of tubes that come down from the gallbladder. Those can get inflamed. So not uncommon to see somebody have an attack, especially with higher doses. It's something I'm looking for all the time these days. And then they also want to if it's retatrutide, one, it's not quite FDA approved, but it works great.
Yeah.
But about 20% of people get paresthesias, which is numbness and tingling, almost like when you take beta-alanine. That's in a lot of pre-workouts. If people aren't familiar, Derek calls it itchy butthole because he doesn't like beta-alanine. I like beta-alanine.
I think at the right dose and using the right circumstance, it's nice to kind of have that like tingly, like feel like you're ready to get going.
Yeah, and if you use it every single day, which I actually do,
okay,
it's kind of like creatine, then you kind of lose the paresthesia effect. But yeah, the paresthesia effect from retatrutide is generally not too enjoyable. So if a lot of people are not getting the paresthesia effect, but it's because they're taking Chinese research chemical retatrutide, it's not from a pharmacy. You can get it from a pharmacy, it's just very difficult. It's because it's kind of like whack-a-mole when they make it. But yeah, a lot of people are just taking tirzepatide.
So I'm going to take you off on a side tangent here. So you talked about beta-alanine on a daily basis?
Yeah, there's some evidence that, kind of like how if you take creatine daily, you can stockpile it.
Yes.
And it builds up. Beta-alanine is kind of the same way.
Interesting.
So the best evidence as far as a performance enhancer is if you use beta-alanine consistently rather than a one-off. It gives a nice tingling effect, which I kind of like because if I feel that, I know, oh, it's about time to work out.
Yeah.
But yeah, that is best to use it that way.
Interesting. Yeah, I think of it kind of like it just wakes you up nervous system wise before you take it, that tingle feel. When is a situation where GLP-1s maybe make more sense or less sense for someone who is looking to change their health outcomes and specifically is dealing with obesity?
Yep. The easy no would be if there's a strict contraindication. For example, a family history of specific types of neuroendocrine cancers, strictly contraindicated. And then the other one that's, just like not a great candidate, if they can pretty easily improve their body composition without it. So let's say maybe a Zoomer that just wants to be a little bit more shredded for the summer, could totally get shredded for the summer without any help.
Yeah.
And they're using this. There is unknown longer term downsides, especially with retatrutide, but often you rebound. So it's almost like you're using a tool, but in a bad way, harmful way, because you're teaching yo-yo dieting. Because when you come off in September or whatever you do, then you're very likely to rebound for about 2 to 3 months. That's usually about how long the weight regain is. So I usually use other things like low dose naltrexone or apelline, the grillamine product, or there's a lot of other like over-the-counter products and prescription products that I have people do for about 3 months after they stop a GLP-1.
Yeah.
And yeah, you can wean down the dose and whatnot, but if you don't need it, then you shouldn't use it.
What are some of those things? So say I'm somebody who is like looking to, create a little bit of an edge, or I've kind of run into a plateau on my weight loss or my fat loss, and I am not quite ready to like go all in on a GLP-1, but you mentioned other over-the-counter or supplements or other medications. Like what other suggestions would you have for someone who maybe isn't quite ready to go down that path, or they run into the contraindications around like the cancers and other things that could be concerning?
Yep. I mentioned the 30 plus grams of fiber. I like psyllium powder myself.
I've heard people talk about psyllium powder.
And also sun fiber. Psyllium powder is more of like a thick viscosity powder, whereas sun fiber is fully soluble, kind of like creatine actually, tasteless. So one or both of those. And then as far as protein, instead of just more whey protein, there's so many other options that are good. There's different beef proteins. There's albumin protein, which is egg white. I often take the naked egg protein, which is just albumin protein.
Yeah.
And then there's also casein protein.
Yep.
So that's going to lead to more satiety and be slower digested. And I'm not as worried if somebody wants to take, like a really high gram shake.
Yeah.
If you're taking 60 grams away, probably not a great idea. If you're taking 25 grams away and then 15 grams of a different protein powder, that's going to lead to a better satiety.
Yeah, well, it makes sense. You hear a lot of people talk about how much protein can you actually digest in one setting. And to your point, like a lot of those mass gainer type shakes typically have a multitude of different types of protein mixed in so that you do digest at different rates. So I think that's something people don't always think much about.
Most fat burners are overrated from a standpoint of they're not burning fat, but I actually do take specifically Cycline AM. It used to be called A2AM, another grillamine product.
Yeah.
Which I'm biased towards them, of course. So, so just to like state my disclosures, if you will.
That's fine, yeah.
But I have a lot more mental energy when I take it because people have seen natural bodybuilders. My CFO, Derek, the accountant, he was like a week out of his bodybuilding show 2 years ago, and he's walking in and he looks like a literal zombie.
Yeah.
because, he's really restricting
Heavily
and
depleted. Yeah.
yeah. So it does help to take things that can boost up your energy to some degree and help with cognitive performance. Ketones can do that too, but be careful with ketones because they have calories.
Yep.
They actually have 7 calories per gram, kind of like alcohol.
Okay, I was gonna say very very similar to alcohol, but can be converted in energy in a different way than what alcohol typically would be. Correct?
Correct. Yeah, there's actually kind of 3 main types of ketones: ketone esters, ketone and ketone salts. And the ketone scientists disagree about like which one's better and whatnot. I tend to like ketone salts and agree with Dom D'Agostino,
Okay.
who's a PhD at USF and puts out a lot of good content about ketones. But an interesting one is ketone, which I wouldn't use too much because I think I saw a study that it still led to maybe some liver fibrosis. But alcohol is ethanol. And after it's metabolized via alcohol dehydrogenase to acetaldehyde, then it's metabolized from acetaldehyde via acetaldehyde dehydrogenase. Whereas ketone, I think it's 1,3-butadiol. So it's actually not a ketone. The liver converts it via dehydrogenation into an active ketone. So it kind of makes you a little bit buzzed. So every once in a while, I drink 2 of those hard ketone drinks.
Okay.
Yeah.
And that's kind of like your fix.
Kind of. I mean, it's socially beneficial to drink something that makes you feel fun or silly.
Yeah, 100%.
Yeah, it doesn't make me feel warm, but it makes me feel cold.
Yep.
And I feel, just kind of a little keto buzz.
Social lubricant, if you will.
Kind of, yeah. So there's no health benefits to alcohol, certainly, but there might kind of be some social benefit because it's some primal bonding, that we have been doing for thousands of years.
Yeah, for sure.
So fortunately, the technology's better now. We don't have to do it with ethanol.
Yeah. Well, it's interesting enough because I think that that's one of those pillars that people either like all the way in or all the way out on. There doesn't seem like to be a whole lot of happy medium. But you talk about it from a social perspective. We take kind of the same approach where it's like, okay, in moderation, it's going to be okay if that gives you the opportunity to create that social pillar. Because as you said, that's a huge piece of the puzzle.
Yeah. I think a reasonable rule of thumb would be don't drink more than 24 times a year.
Okay.
Over 12 months.
That's a really good takeaway.
Not more than 24 days. Don't drink if you're by yourself. And probably don't drink if you're using it like a self-medication.
Yeah.
It's not a good self-medication because you actually withdraw from it. I mean, it's binding that GABA receptor, almost like a Xanax or an Ambien. After that wears off, you have a rebound effect where it's like a lot of people get anxious and stressed afterward.
Yeah, I think that's a really good way to frame it. When you say 24 times a year, the people who enjoy a drink or two might say, is that 24 drinks a year or is that 24 settings of drinking a year?
Technically, it would be settings of drinking. And, this last year, I have a 1-year-old and a 4-year-old and a 6-year-old. I probably drank twice, maybe 3 times. I did not drink often. But generally, if your spouse is like either pregnant or breastfeeding, you're probably not drinking.
You're not drinking much at all, yeah.
Maybe a few times. So the goal is not to get to 24 days per year.
Yeah, for sure.
But it's more of a thought of, if you're drinking pretty routinely every weekend, I think that also leads to some cumulative health detriment. And most people that drink socially drink with their family or on the holidays, Thanksgiving, Christmas, etc. So that's the end of the year. So it gives you a target to look forward to really save up plenty of days and be judicious.
Okay, cool. I think that's a really unique frame. I don't know that I've ever heard anybody really like frame strategically navigating that maybe the same way.
Yeah. That being said, you look at the studies on people who do a lot of drinking. It's people who admit on surveys to doing a lot of drinking or that have been hospitalized with it. I believe I saw a study that said something like 5% of people drink 90% of the alcohol.
That's insane.
So a second, much lower goal would be certainly don't be in the 5%.
Yeah.
But
5% with 90% of the consumption.
I believe I saw something like that. Someone might fact check me, but it makes sense. It's kind of like the Pareto principle.
Yep.
Some people call it the 80-20 rule, their 90-10 rule.
We talk about that a lot.
Yeah.
Yeah.
So it's probably true.
Yeah. Well, it makes a lot of sense. So let's circle back to the role of exercise and metabolic health, because I know we've talked about like GLP-1 and hormones and metabolism and other things, but can you talk more about that pillar of things from an exercise standpoint on obesity and how that influences it?
Yeah. So exercise can kind of be split up into a couple different categories, but the shtick or the saying that I use is everyone needs to find a movement pastime to last a lifetime. The most important thing is consistency. And yes, ideally you have at least 1 day a week where you do aerobic exercise and at least 1 day a week where you're doing resistance training. That would have to be like really some full whole body resistance training if it's that. So, it's better to be balanced between the two. But the most important thing is just that someone likes it. So I see, there's a lot of people that just really love playing pickleball, and you could probably get by with playing pickleball 5 days a week. And then you have, depending on how you play, you might need like a high intensity workout on top of it.
Yep.
Not to hate on it. Like, you can get a decent sweat.
Yeah, for sure.
And then you might also you definitely need, in my opinion, some strength training on top of it, if not for any other reason than to prevent injury and to prevent dementia, actually.
Interesting. Talk more about the dementia side of things and what the value is on that end.
Correlation between lean body mass, muscle mass, and brain mass is the closest. So it appears that resistance training is the most important modality of training to prevent neurodegenerative disease.
There's so many mental health benefits on the strength training side, so it's neat to hear the correlation to that and the natural cognitive decline that happens with dementia and how there's actually like a connection there, not just like the way that you feel after you're done with something.
Yeah, definitely. The habits that you get into training are also somewhat applicable to cognitive training.
Okay.
So they've actually looked at studies and, doing crossword puzzles is not the best thing for dementia. I actually just did a podcast with my friend Tommy Wood on the Gillett Health podcast. If people want to listen to more of my sarcasm or whatnot.
Oh, well, we will not leave without letting them know where to find you.
But anyways, we were discussing what's the best video game for that. And well, video games are not ideal, but the like very simple video games or Sudoku or whatnot, we used to think that those are great for preventing dementia, but it's actually new experiences. You're going to new locations. You're pushing your brain to train it, almost like a progressive overload, which is, there's a lot of correlation there.
I don't think people think of it from that perspective, like see, do, here, now, not so much go out and physically experience expanding the brain.
Yeah, but there's a lot of, it's kind of difficult to discern because a lot of people who retire very late also have relatively poor health. Past a certain income level, you tend to live much longer as well. And then beneath a certain income level, you tend to live much shorter. I posted this graph in one of my recent podcasts, life expectancy very short for very, very low SES, and then very long for very, very high SES, and then a more gradual curve in the middle. But if you retire very late, then often you do die very early, but it's probably because of health reasons. If you retire extremely early, very likely very high SES, you do tend to live a very long time. But for the same person, if that specific person just decides to retire later or even change careers and get a second career after typical retirement, that person is actually probably going to have less dementia.
Over the course of that time frame.
Probably so.
Well, it makes sense. I mean, I think you hear people talk about this the second you stop like working, you start dying. You know what I mean? And especially when you talk about the income demographics and the decision to retire versus the opportunity to retire being two very different things.
Yeah, it's somewhat of a use it or lose it situation, but it almost might be more beneficial to have kind of a post-retirement career switch compared to working that same job that is not, it's very easy to you.
Almost like a intentional late life transition in career, even if it's not something that you can like completely transition out of from a financial dependency standpoint, but just like switch instead of like a hobby job it. You know what I mean?
Yeah. And if you're working for fun, then you're less stressed and you're more happy.
You're trying new things. You're getting out of your comfort zone. You're having, like you said, it's enjoyable.
Yeah. Yeah. When I recruited Dr. Mark Gillett to leave the job that he'd been at for more than 3 decades and join Gillett Health, he was extremely happy and he can work as much as he likes. He doesn't have, he doesn't have as many duties. And I think that has been great for his career. And, it doesn't necessarily have to be even in the same profession.
Yep.
I see people that, they decide to go do something outdoors and they're like, hey, I want to advise for, crops or whatnot, or go to work at a fishery. So there's a lot of things that people should do for their brains, but they're only thinking about their bodies. So that's the good thing about a body is, you can do body composition scans. It's relatively objective. The technology will be there eventually for brains. Like right now we do brain key MRIs.
This is something you and I actually talked about because I've had some concussions and played very aggressive sports that involve acute, repetitive, not necessarily like serious every time, but brain trauma. Very interesting to me. Sorry to interrupt you there. It was just something that I remember us talking about.
Yeah, it's just a matter of time until that technology gets better.
Yeah.
And I do think that's one area, especially medical imaging, that AI is going to be crushing within 2 years, really.
Yeah. That's that one thing I think we could probably have an entire episode on. And if you've had episodes talking about like the use of AI in medical science, I'm sure that you've delved into that because I know that Sage Bio is like partially.
Doctor AI.
Yeah.
It means it's my AI doctor, but it means not doctor.
Yeah.
If you look at on Reddit.
That's awesome.
Yeah.
Well, cool, man. I don't want to keep you on here forever, but I do have some things I want to just kind of give your perspective on. So I like to do quick hitters with folks sometimes. So I'm just going to run through a couple of like quicker questions and just get your visceral response and thought process on it. So number one, what's the biggest myth about obesity?
Biggest myth is that BMI matters. And it's becoming less of a myth, but it's still the biggest myth.
Yeah.
So, like waist circumference or body composition matters a lot more than BMI.
Yep. I would agree on that one. That makes sense. What about the biggest mistake people make trying to manage obesity?
I would say the biggest mistake healthcare providers make is just pumping up GLP-1 doses. The biggest mistake that people make is they'll see a friend or a family member and they will think, well, this isn't right for them. Let's just use a GLP-1. My family member did not need to be on tirzepatide or retatrutide, so I'm not going to do it. But it might be the thing that helps them the most.
Yep.
So don't get skewed because of what you see with somebody else.
Yeah. And structurally, what worked for them won't maybe necessarily work for you.
Yeah, that's why I call my service individualized medicine. It's everyone is their own unique physiology.
Yep, we practice the same approach, man. I love it. What is the biggest thing that you think people misunderstand about metabolism?
Most of a burned or crashed out metabolism is that someone's been trying to restrict a lot and they're just not moving and or they're not exercising a lot. Usually more so not moving, that they're just very low energy. So the hormones themselves don't matter that much. Yes, if you're low testosterone, you're not going to be moving as much. Yes, if you're like if something is off with your neurotransmitters, that's the case. But yeah, a burned out or a crashed out metabolism is not as physiologic as most people think.
Yeah, because you hear a lot of people say like, well, now that my metabolism is slowing down, and I'm like, is that really an age-related thing? Because obviously there's certainly some level of that, but...
Yeah, the other thing is lean body mass is at least twice as metabolically active, twice as many calories, pound for pound, as body fat.
Yep. So a couple of other things just to kind of tease into where you're headed with things you're focused on. What are you most excited about with what you see directly happening in the relatively near future with your industry and the things that you're working on?
Yeah, I'm of course very excited that more people than ever are into wellness. The wellness industry is massive. It's basically rivaling big pharma, and big pharma is good too. They just needed some competition.
Yeah.
So I hope that people are going to become healthier and healthier. It's becoming easier to get certain medications approved at the FDA, and the peptides that have good clinical data and that are bioidentical, et cetera, those are becoming easier to use and prescribe and make at compounding pharmacies as well. And there's more and more that are getting approved, like elamoprotide, even a few months ago. So I'm very excited about the technology of the space, but even more excited about how the culture is accepting preventive medicine and wellness.
Yeah, I would agree with that, man. Very cool. So where can people find you?
Yeah, my main hub is on Instagram, Kyle Gillett MD, Gillett Health Podcast I mentioned, and Gillett Health on all other platforms.
Awesome. Anything else that you'd like to share with the audience before we shut her down and steer them your direction to check out more?
Yeah, I guess since it's a local audience, I do have a local aesthetics and med spa clinic, and we do free consults with that. I also do, myself and my colleagues do peptide consults. If they don't want a full membership, they can come in, and a lot of people just ask us, hey, I just heard from my friend at the gym about BPC 157, TV 500. Can you explain to me the risk? Is it actually a cancer risk, et cetera, et cetera? So we offer those as well. And then, yeah, if they do like listening to podcasts, which I'm sure they do if they listen to this one, then yeah, we'd love them to listen to mine as well.
Well, hey, thank you so much for your time, and you're an absolute wealth of knowledge, and I'm sure that we could have talked about many, many other things, but check out Kyle and his podcast, and if you're in the local area, go check him out at Gillett Aesthetics and Gillett Health. Thank you guys. We'll catch you next week.
This episode of the Higher Form podcast is powered by Avexia Health and Performance, your home for smart training, simple nutrition, and real accountability. Built to help you look, feel, and perform your best. Whether you're just getting started or chasing your next level, visit AvexiaKC.com to learn more and start building your higher form today.